Hey, good evening, everyone. I'm Andrew Penn. I am one of the co-founders of Open Nurses, and it is my pleasure to introduce our interviewee subject today. Subject, that sounds funny. Ronica Mukerjee. Dr. Ronica Mukerjee is a family and psychiatric mental health nurse practitioner, as well as an acupuncturist. Dr. Mukerjee is an assistant professor at Columbia University School of Nursing, where she teaches psychedelics and provides both hormonal care and psychiatric care for trans and gender diverse patients. Dr. Mukherjee's co-edited book about abolition and health justice, All of This Safety is Killing Us, was published earlier this year by North Atlantic Books. So we're going to get into all that tonight. So let me bring Dr. Mukerjee, Ronica, onto the screen here.
Hi.
Hey, Ronica, nice to
Hi.
see you.
Nice to see you.
Thanks for being with us tonight. Um, your bio is brief but intriguing. So we were just talking before you came on camera about how, all the different ways people get into nursing and find their way here. So let's start there. Tell us, how did you get into nursing and what brought you to this point?
Yeah, thanks. So, before I was ever a nurse, I was and am still an acupuncturist and have been for 23 years. And even before that, I taught like self-defense, primarily for street and strip club involved sex workers, which later translated to teaching martial arts and having an acupuncture practice in New York at the same time. And I've worked a lot of jobs at the same time. So if you're like, how did you do all of these things? I work a lot of jobs at the same time. So in my sliding scale acupuncture practice, which went down to $10, I did not make enough money to survive. And so I started, but I loved it, right? And I knew that I wanted to always continue to do that work. I was seeing a lot of people with neurological disorders, which was poorly treated by Western interventions, as well as HIV positive patients. Because if you remember in the 2000s, a lot of the HIV medications had a lot of neurological side effects as well, and other side effects that still happen, but less with the newer HIV regimens. And so I decided to become a family nurse practitioner because I wanted to do the HIV treatment part, as well as care for queer and gender diverse people, basically people in my community who are getting inadequate health care. That happened. And I also delved into psychedelic work, as in within more professional settings in a couple different countries, the last of which I'm shortcutting here, was in Mexico, where I co-founded a refugee clinic in 2019. And I lived on and off for 4 years in Tijuana doing free care, including a free trans care clinic for migrants. And people using substances. We were right next to the canal in Zona Rosa, which is where a lot of people who are substance using and living on the streets lived. And I continued to do gender affirming care via telehealth. I also had a private practice in Connecticut while teaching at Yale. I went back and forth, and I had some esketamine patients between 2017 and 2021. And while in Tijuana, I worked with curanderas from Mexico, working with natural forms of DMT. And I also started working at an opioid overuse prevention program at a syringe exchange, and I did that for 4 years. Alongside, I started an Hep C treatment and PrEP and PEP program there as well. In 2022, I started doing ketamine-assisted therapy and prescribing as a psychiatric mental health nurse practitioner. I went back to school because I didn't have enough on my plate, and and I started combining that with acupuncture. Not at the same time. That's usually the first question that people have, like, "Are you doing acupuncture while people are on ketamine?" No, I'm not, because I'm a
Although maybe there's something to explore there. Who knows?
well, Chinese medicine would disagree, but maybe
Okay.
Western wouldn't. And so have been doing that and combining this with psycholytic ketamine dosing with EMDR, and just regular EMDR more recently. I love body-based somatic approaches. I do a lot of physical medicine stuff in my primarily psychiatric and gender affirming care practice now. And because I believe that the somatic stuff, there's many ways of getting there, but for me, that really helps me kind of get to those hard to tell or untold stories that are within the body. And I really believe in that kind of medicine.
Wow. Okay. So, so many questions. And also want to encourage folks that are watching this live to go ahead and first of all, put where you're watching from in the comments, and also later if you have questions as we're talking, feel free to put those in, and we'll get to that towards the end of our conversation. So I'm really hearing, there's a few themes here. Like one is body-based somatic work throughout all these different modalities, and the other is really just sort of taking care to where people need it. Kind of, I mean, it's one of those kind of truisms in psychotherapy and nursing school, like meet people where they're at.
Yeah.
You were like literally meeting people where they were at, and giving them what they needed wherever they were, which, we don't always do a great job of.
I appreciate you saying that. I really believe in refugee work and working, so much of the world is refugees, right? Whether or not they're identified as UN refugees or they're internally displaced people, but so much of the world is fleeing from something, from some kind of oppression, subjugation, violence. And like, I want to be a part of, creating a path forward.
Yeah. And as you were talking, I was thinking about the last time I had acupuncture, which was a while ago now, but for some allergies that I'm prone to getting, I just remember there's kind of a stillness that comes over you when you're
Yeah.
sitting there with these needles in, maybe because you're, afraid you're going to skewer yourself or something. But as you were saying that, it made me think about how it's sort of a similar stillness that people often have at the end of a psychedelic session.
Yeah.
There's just kind of a quiet that comes over you. And I'm wondering if you see a parallel in those two states, and is this sort of different pathways to the same place?
Yeah. I mean, I don't think everyone is going to resonate with this idea, and I love that, but I really do think they're both about getting people to homeostatic energetic states. And what does homeostatic mean? That is very different for every single person. And that's what I love about acupuncture, is that it's bringing a person to what is available to them in terms of a homeostatic state now. And I think that's also true for psychedelics, right? It amplifies what is possible in terms of someone's mental process and physical process with the psychedelics too.
Yeah, yeah. And going back to that question around sort of getting people care where they need it, no matter sort of what their circumstances are. I mean, this is a real tension in the psychedelic space right now, right? Is that like, okay, how these are, potentially great treatments. How do we get them to people in ways that are scalable and affordable and accessible and equitable and all those things? And I know from previous conversations that we've had that you've given this question a lot of thought. So I was wondering if you could share some of those ideas with our audience.
I make enough money. I really do. And I think a lot of us do as nurses. We live in this state of scarcity that is about the way that the hierarchy of the healthcare system works, right? Where we are constantly taught that we don't have enough, we are not enough. And then we believe in that, and we sort of pass that on to our patients. I think it's important for us to do things that are accessible for us, like offer care at amounts that are okay for us to do it at. I think it's important for us to offer alternative modalities like group work, online work, things that like kind of, aren't necessarily about renting a space or creating more cost for ourselves. And also sometimes I think it's important to do free care, right? Like lawyers do that. Lots of people do that, right? Lots like people with licenses do that. And I think we should also do that. I am specific about people who I will do free care for. I specifically do it for people who've been affected by carceral systems, whether or not that's border-based carceral systems, prisons, or juvenile detention systems. Like that's who I do free care for. I feel very passionate about that. And I don't do free care for everyone either, but I think it's important for us to have those kind of modalities available to people who.
Yeah, yeah. It seems like a real tension between this sort of working within inside of a broken system, right, where we don't have universal access to healthcare, and then sort of punting that, making up for that to individual practitioners, right? So it's like, I remember that old bumper sticker that said, like, it'll be a great day when schools have all the money they need and the Air Force has to have a bake sale to buy a bomber. It's like that flipped around, right? So like providers are being said, well, since we have a broken healthcare system, well, you can make up for it, right? By seeing people, for free, which many people do. Um, and I think that's valuable. I mean, critical. Like, a lot of places couldn't, a lot of people wouldn't get care if it wasn't for that. And at the same time, it also feels like we're kind of perpetuating this like
I
broken
agree.
system. And I
I
don't know how
agree.
to solve for that.
I mean, I think we know how to solve for that, right? Which is universal healthcare. And like, we are not in charge of solving for that. And that's
right,
part of the problem, right?
right,
So
right.
we make the interventions that are possible. But yes, it does feel like pulling people out of a river that they've been forced into, for sure.
Yeah, yeah. And I want to go back to something you said about the kind of acculturation we get as nurses
Hmm.
around this, because I think this is so valuable. And so, I always tell my students, like, therapy is about making the implicit explicit. And I
Hmm.
think that's something in our conversations, I feel like you've sort of called things out as to name them. And that, when I hear that and around nursing, that really resonates, that there are these messages that we've sort of been brought up with, that maybe we haven't really begun to question. And this idea of, like, well, you're not good enough and you should give your work away for free,
Right.
is a really, that you're not worthy of this, seems to be, a thread that runs through a lot of our profession.
And also that time is money. Like my time, you cannot pay me enough for my time. Like there's no money value that is high enough for the amount of time the way that I want to spend time with people most intentionally, right?
Hmm.
So like the idea that our time is worth of a dollar value obviously is rooted in capital, right? Like we
Hmm.
have, so if we value ourselves in terms of capital, we're never going to be enough.
Hmm. So the value has to come from something other than just monetary.
Yeah, and practical too, right? We have
Yeah.
to pay our bills, but like, yeah.
Yeah, yeah, for sure, for sure. Yeah. Um, yeah, it's intriguing. It's really, I mean, there's such interesting tensions here, and then how this maps onto psychedelic space, because
Mm,
a lot of people would love psychedelics to somehow be free and available to everyone, yet nobody seems to want to work for free, which
yeah.
is understandable. I certainly can't do that very often, and you probably can't either. So, I'm always intrigued, like, how do we solve for that? How do we not make it something that's, $3,000 cash per
Mm,
session, and at the same time have people get compensated for their labor and their time and work and expertise. Um, yeah. Uh, when we figure that out, let's share the
yeah.
share the
We'll read that
solution.
book together, Andrew.
Yes. Well, speaking of books, I want to hear about this one that you've written. So, in our promotional copy for you, we had you cited as an abolitionist.
Yeah.
And when I think of abolitionists, I think of people like Harriet Tubman.
Okay.
So contextualize that word for us in 2025.
Yeah, thanks for asking. So, abolitionist, well, abolition, let's talk about abolition. So, abolition, obviously, there's old terminology that's really about the freedom of enslaved people. But right now, what it really means is um, to be involved in working towards the eradication of imprisonment, policing, detention, and surveillance, and kind of creating lasting alternatives to punishment, deportation, and incarceration. We know those things don't work, right? What happens to people when they're incarcerated? When I worked in Tijuana, like, sure, the majority of my patients were migrating from elsewhere, but a good number of them were deportees living on the border who had served in the military, who, like had done all the things that you would think a quote unquote American citizen would do, and were still denied the benefits of American citizenship, right? And it's the same family of like, a deportee and a refugee. That's the same family. And so when we're talking about that, what does that mean in terms of healthcare? So abolitionist health justice is really seeing carceral systems as the root of many health inequities and disparities, and focusing on removing barriers, including carceral ones, to healthcare in order to actually improve the health of actually all people. Because we know that that's not what healthcare has been doing. We know that mental health care has not been doing. Who accesses mental health care the most? We know that that's not what like regular old Western family medicine, internal medicine hasn't been doing that either in ways that are meaningful. We see those health disparities huge. And where health disparities have the least amount of importance is within prisons. So Black and white people within prison have the same exact access to healthcare, but not before and not after. And that's
Wow.
Right?
Yeah.
So, like to me, that's such a stunning fact, and also pretty unacceptable that we have sort of codified that these carceral systems are not only going to be intertwined with our medical systems. 97% of hospitals have police officers in them, right? And we don't know how to deal with crisis, but healthcare is a crisis for most people who are accessing, especially within healthcare emergency settings. That's my long-winded answer for you.
No, let's go deeper.
Yeah.
And so in so many places, the first people to deal with a mental health crisis is law enforcement.
Exactly.
And I know this is one of the issues that they were grappling with in places like Oregon, and will grapple with in places like Colorado. So if somebody goes to a above ground state legalized psychedelic session and has a difficult experience, who's going to end up intervening if the situation kind of gets out of the control of the people facilitating the session, or that person begins to put themselves in, or God forbid, somebody else in danger. We know it's probably 911, which is going to bring the police, and that always, as a mental health clinician, I mean, I really don't like doing welfare checks.
Exactly.
I really don't like calling for welfare checks, particularly for people of color, because I just know that just raises the stakes. I mean, police officers understandably don't like going into situations that are really unpredictable and, potentially risky. And then you add, the potential for, racial bias in that, and it's dangerous.
It's dangerous. Crisis is dangerous for someone in a healthcare crisis. If you're trans, if you're a person of color, if you have a disability where you can't hear, or you have communication differences from the general public, then that creates danger for people. One of the people, so I didn't actually fully write this book, All the Safety is Killing Us. I co-edited it and I wrote some things in it. But one of the people, two of the people in the book, Naomi Schoenfeld and Jennifer Steen, wrote a chapter about, it's called Crisis Limits, about people, their 911 alternatives to police showing up to crisis situations. So like you call 911 and they have a crisis team that has a social worker and a nurse and or a nurse practitioner who show up to that crisis, and how that has created these ties and increased trust, particularly in poor and Black and brown communities. And that's really the kind of stuff that we're talking about when we're talking about abolition, is like, how do we make people safer? Because we know that's not what's happening with policing. And also, one of the ways that we know that policing is not safer is that we have no statistics on violence really around policing. We used to, and it was only some states that opted into that. and the statistic is that about less than 50% of police violence was reported. And now we're not going to have that at all anymore because the MMWR is much diminished from so.
What was the abbreviation of the thing that you just mentioned?
The what? I'm sorry.
It was a little garbled on my end.
The MMWR.
Which,
the CDC Morbidity and Mortality Weekly Report. Yeah.
Right. Yeah. Okay. Because that's been defunded.
MMWR. Which, CDC Morbidity and Mortality Weekly Report. Yeah.
Right. Yeah.
Is that
okay? Because that's been defunded.
MMWR. Morbidity and Mortality Weekly Report. Yeah.
Yeah. Okay. We've got a ghost in the machine. I'm gonna mute both of.
I don't.
Oh boy, this is the first time this has happened. We've got ghost in the machine. I'm gonna mute both of them. Wow. Oh boy, this is the first time this has happened. We've got ghost in the machine. I'm gonna mute both of them. Wow. Oh boy, this is the first time this has happened. All right, let's see if I talk, if it works. Let's bring.
Hello.
Okay, let's bring you back in. That's weird. That's never happened before.
Sorry, I don't. It might have been me. I hope
no,
not.
no, it's
YouTube open.
yeah. I was like, I'm hearing voices, and they're my own voice, which is even worse.
I'm glad it ended.
Okay, good. Sorry about that.
No worries.
So I'm thinking about, like, as you're teaching your students there at Columbia, where does this show up in the curriculum? Like, many of the people watching this here will have gone to nursing school. We have a sense of what our curricula look like. Where do these sensibilities and these ideas show up in the things that you're talking about and the things that you're teaching?
Well, for a few years, I taught health promotion, disease prevention, and really how I taught it was through a carceral systems perspective, looking at how borders affect immigrants and also Latin and Native people who live within the borders. Like, we know, for example, that people who live within the 100-mile radius of the border who are Latin and Native have 2 years less life expectancy than Native and Latin people in other parts of the country. We also know that, I don't need to tell you that prisons have a lot of health effects, right? Including the fact that people's risk of overdose is 10 times higher after imprisonment, because oftentimes there is not great treatment and or ability to actually process people's traumas that often are part of the addiction process, right? And substance overuse process for most people. And so, I would teach about these things because I really, for me, we know that people who have a lot of money often have better access to healthcare. So I don't really need to promote health in those populations, right? I need to promote health in people who are not getting it, that queer and trans people are not getting good access to healthcare, that immigrants are not getting good access to healthcare. And so in order for us to increase that, we need to understand where that historical oppression comes from. What does it look like for these communities to have experienced systematic exclusion for hundreds of years? And also, especially right now, right, administratively, we are particularly experiencing that systematic exclusion. But anyway, so I taught that kind of stuff. And then, I teach intro to addictive behaviors, which I teach through a harm reduction approach, and thinking about, how do these molecules work? And, like, why would you choose them versus, I don't know, eating dinner at a fancy restaurant? But what's the goal? Like, what's dopamine doing for you? What's your history of trauma doing? What's historical oppression doing in the room when someone is using a substance? And also, how do we make it easier for people to use substances and also talk to their providers? And also that we don't treat psychedelics, and especially within a clinical setting, like these are so good and heroin is so bad. Right?
Hmm.
Like we know that, for example, methadone increases BDNF, right? So like
Hmm.
if we're going to talk about BDNF and the BDNF chase with psychedelics, we need to understand that there are other substances that are involved in that, and that taking heroin can be a beautiful journey also.
Yeah.
So,
Yeah.
yeah.
Yeah, buprenorphine was almost approved as an antidepressant back in 2018 in a combination with samidorphan, but it seemed like not a great time to bring an opiate to the FDA for antidepressant
Thank you, settlers.
approval.
Yeah.
Yeah, right. But yeah, you're absolutely right. And Carl Hart, of course, has written probably
Yes.
most notably, most sort of in popular literature about that. His drug use for grown-ups, I think, was
Mhm.
was provocative for a number of people in the psychedelic space who, will often talk. I mean, it's interesting, even just in the. I'm kind of an interesting. I have an interest in sort of the discourse in psychedelics and how we often will do this thing of like, well, it's um, LSD and psilocybin are in the same group as the same category in Schedule One, which is the same schedule as heroin,
Right.
you know,
Yeah.
and and then people make them say, and methamphetamine. It's like, no, actually, methamphetamine is a Schedule Two drug because you can prescribe it if you want.
Right.
It's uncommon, and you probably
But yes. Oh
yes.
no. Oh no. Obviously for ADHD. Right. Yeah.
Yeah,
Yeah.
yeah. Well, no, I mean Disoxin.
Right.
It's a prescribable amphetamine. You'd probably get the DEA paying close attention to you if you start
Yeah.
doing that, but it is actually a commercially available drug.
And also LSD and psilocybin. Those are pretty different
Yeah,
from one another. Like the scheduling of the drugs really doesn't reflect how they interact with the body so much of the time.
no, no, they're really, they're they're really quite arbitrary most of the time. But let me ask you something about this sort of this social justice lens on healthcare. So I read an interesting thing. So we have a new mayor in San Francisco, and during the
Yeah.
pandemic, San Francisco, like a lot of urban cities, a lot of urban places, got a little bit ragged in places, and to the point where I mean the Fox Media folks really latched onto it as this failed city and blah blah blah, which was we would sort of, those of us who live here would joke about this dystopian hell that we have to live in with you know nice weather and good food and all these horrible things that we have to endure on a regular basis. I actually had a pilot on an airport shuttle in Chicago when he found out that we were from San Francisco, kind of lean over and in like sotto voce say, is it as bad as we hear? It's like, yeah, we had to sneak out under the cover of darkness, man, But seriously, I mean, that was the perception, right? And so we
Yeah.
get this new mayor because, these political swings and so new mayor, much more sort of business aligned, much more centrist than the previous mayor. And the first thing he does is sort of it's an optics campaign, right? It's like we're not going to let people camp on sidewalks anymore. We're going to crack down on public drug use, though, but we're going to open sidewalk bars. That one always kind of it
Right.
amuses me, right? It's like, well, there's a supervised consumption site,
No.
for
As long as
alcohol.
you're making money, you can be on the sidewalk.
Well, right, yeah. And so where this is all going is that recently there was a report that our overdose deaths are up again,
Hmm.
because what's happening is, people are getting thrown in jail. They're going through withdrawal, they're losing their tolerance, they're coming out, and they're going back to using, and they're dying because they've lost their tolerance, so on the one hand, I mean, the city does look less ragged than it did a couple of years ago, so for the average person living here or traveling here or whatever, and some of these like nuisance crimes of like cars getting broken into and such are down, which had, really become, not just a sort of a black eye for the city for visitors, but also just for people who live here as well. But the trade-off is that we're putting people in jail, and then they're coming out and they're going back to using opiates and they're dying. And
Hmm.
so so how do we square for this thing of like, well, people don't want to live in places that feel, really ragged, like we got, during the pandemic. And at the same time, that doesn't mean we let people who use drugs die.
Yeah.
Um, so can we have both? I guess that's what I'm asking. Is there, because it just seems like we do this pendulum, and it just goes back and forth, and neither one is particularly effective or beneficial.
Right.
So
People dying out of the public eye isn't better. Right. That's not
right,
that's not helpful for any city for people to just be dying in a corner where no one can arrest them. That's
right.
certainly not a healthier city. But I think I'm interested in the pendulum, but I'm also interested in the fact that there has been so much resistance to safe use facilities, right? Like, what if we had safe use facilities all over the city?
Hmm.
Sure, the neighborhood, there would be people who would be like, well, I bought this multi-million dollar house in Bernal Heights, and now I don't want a safe use facility. But I bet
Hmm.
they would prefer that if it, I don't know, maybe they wouldn't, but it's hard for me to imagine. But like, there are advantages to having the safe use facilities there versus people hiding in corners or,
Hmm.
having to find random places and or being in danger themselves. Like, can people be reasoned with is really part of the question. And
Hmm.
when people have more resources, they become less reasonable around other
Hmm.
people's rights. So that's just the pattern that has existed. And San Francisco is a increasingly wealthy city. Is
Hmm.
it the wealthiest city in America?
I don't know if it's the wealthiest. I think that might be Hartford, Connecticut. But we're up there.
Yeah, so one of the wealthiest cities, right? Like, it's still got that prioritization, and I do think that the industries that surround San Francisco bring a lot of people from outside of those cities that want the benefits of the cities, but they don't necessarily want the realities of people who are struggling to live
Hmm.
and make it in the city. And like, tough shit is sort of my feeling too.
Yeah,
I
and having been to Vancouver and seen, places where they actually, we had Bryce Koch on here a while back, who I think
Yeah, I do.
who works in a, supervised use facility in Vancouver, and I've toured that place. It's nice, I wouldn't mind living on the same block as it. I don't think these places have to be, I mean, we have rules around bars, right?
Yes.
You can't drink outside the bar. I used to have a cannabis dispensary on my block, and frankly, I'd rather have that than a bar.
Mhm.
It's quieter. There's a security person outside who, kind of keeps people from loitering, and people came and went, and it was sort of a non-issue. So I think you're right. I think these things can be done in a way that you know serves the people who need them and makes these cities, livable places for everyone.
And there's
Yeah.
also these models where people are administering fentanyl to people who are chronically using fentanyl within their clinical settings, right? So people are coming in, there's a nurse, there's emergency services available if
Mhm.
they're necessary, and they're getting to use in a safer environment. Now, does every person want to use drugs in a clinic? Probably not, right? And the clinic is also different than a safe use facility. It's also different than um, using at your friend's house that but like, using in community we know is always safer than using on your own. And that's
Right,
what it does when you push people off the streets, is that it makes people more susceptible to the harms of using on their own.
right, right. That is really harm reduction 101, is that
Yeah.
don't use alone. Um, Wendy has delivered the info that
Okay.
New York
City,
City is the wealthiest.
well, this,
Yes, followed by San Francisco. Yeah.
yeah,
Yeah, yeah,
we're up there.
that makes sense. So let's bring this back to psychedelics, because I mean, psychedelics are drugs, and we're talking about drug policy, and that, so this is all related. But so I'm wondering, like, what are the kind of things that are keeping you up at night with regards to psychedelics, thinking about just sort of applying these same lenses of social justice and equity to the psychedelic space. Like what are the things that stand out for you? And if any of those intersect with nursing, that's even better. But like I'm just thinking about what are the things that are occupying your thoughts with regards to psychedelics and where we are in this very weird current moment where, I don't know, RFK might just write a memo and make us, we all can buy mushrooms at Whole Foods now or something. I don't know. Like I've stopped even trying to predict the future.
I know. It's a weird moment.
It's a
It's
very
like,
weird moment.
I know. It's like the priorities of cis white het men are being prioritized, but like
Mhm.
everybody else is not, right? It's not like these drug laws are going to be helpful for people who are already disproportionately negatively affected by drug laws. But I think one of the things that we as nurses have the right to think about, and I would say should be thinking about, is who we're involved in the care of, right? So if I'm involved in the care of someone who's taking psychedelics, I'm very specific about who I'm willing to sit with. Psychedelics are amplifiers. And for me, I don't need to amplify capital and the more efficient pursuit of it. I don't
Mhm.
need to amplify policing of vulnerable communities or, more effective policing of vulnerable communities or subjugation of Black and Brown people in other places in the world that are in a war-torn state. So yes, I don't take everyone in my practice because I'm not interested in friendlier prisons and jails or making this place worse for queer, trans, disabled, Black and brown people that I care about and who are disproportionately affected by these systems, these carceral systems. Choosing who I collaborate with and care for, to me, is a form of resistance. It's not my only form of resistance, but it's one. And
Mhm.
resisting the current culture and collaborating to create healthier people who I am community with, or I see as like underserved and unable to access the kinds of care that I can offer, is the point for me.
Mhm. Yeah. So can we go a little deeper on that? Because I think, when I think most nurses probably don't think about that kind of selectivity about who we're going to treat. Part of one of those sort of ethos that we were talking about earlier that sort of is like you take all comers,
Yeah.
right? So when you say that you're not interested in making prisons better, like what does that actually translate into? I mean, I'm assuming you probably don't have like prison builders coming to your practice, but maybe I'm wrong.
But I have corrections officers who
Mm,
would like to be part of my practice. I've had uh, prison wardens want to be part of my practice before because
interesting.
they're into natural medicine and they want a combination of these medicines. Um, and I get to make choices about that. Look, I know not everyone has the privilege to make choices about who they treat. Like sometimes we just work in settings where you
Sure.
just see who you see, right? Like that's a different story. But I think when we have choices, we can choose the politics and the ethos that makes sense for us and the world that we envision for the future. Like that's really like, what world do we want to see? Do we want to see a cuddlier prison, or do we want to see like, you know, people who are flourishing and come from what have been historically disadvantaged communities?
Yeah. Yeah. And where do you see the potential for psychedelics being misused?
Um, I guess, what do you mean? Maybe clarify your question
Well,
for me.
yeah, sorry, that was a really vague question. But like I think, I know, like for example, some of the critique that came from symposia, aside from
Okay.
the commentary about maps and Lycos and such, was they wrote that paper about right wing psychedelia and the way that these things have this sort of pluripotency, that lest we think that people take psychedelics and suddenly they have this you know kumbaya moment and everyone's going to love each other. I mean, Elon Musk is a good example of how that doesn't always pan out, right? And so, I'm just wondering, do you see potential sort of socio-political perils with psychedelics that maybe we're not considering in this sort of very effervescent moment where psychedelics are going to fix everything?
I mean, like many tools, they can also be weapons, right? Like, and I think that that's true in the way that psychedelics manifest in communities. So, are we making CEOs, and look, I'm not trying to vilify every CEO, that's not my point, but CEOs of companies that like do terrible things in the world, are we making them more powerful and more able to envision the thing they were already envisioning, which, like I don't need to make BlackRock contractors better at their jobs, right?
Mm-hmm.
Like we know that's not good. We know that mercenary soldiers are not a good part of our world. So like I think in that way, it's less about it is about the choices we make, but I also think it's about people choosing. Oftentimes when people come for psychedelics, they want to be more efficient or creative about the life they already lead, right? And so that's where I see the potential like amplification as being negative. Maybe I wouldn't call that
Uh-huh.
misuse, but yeah.
Right. And one of the places where I definitely struggle with this a little bit is around the intersection between militarism and psychedelics, right?
Yeah.
So, I mean, I think we can all agree that veterans per se, are not the bad guys in this story, right? These are often people that end up in the military because of disadvantage and whatnot, and get harmed because they don't have other opportunities to go, places where somebody with more means might go to. But if we so nobody's going to disagree with the idea that we should treat somebody who has PTSD from military experience. But what if we get to the place where we're using, say, MDMA to make somebody recover from their acute trauma more quickly so we can put them back on the battlefield?
Exactly.
I mean, what are the ethics of that?
Right. That's what I'm talking about too, is like we don't need more amplification of war. We don't need more amplification of violence in places where that we cannot see and that is not well covered by the media, right? Like we don't even know. Most Americans have no idea all of the places that America is creating war. So if we don't know that and we're not invested in accumulating that knowledge, then making more efficient soldiers I think there's something unethical about that. So,
Yeah. And then I wonder what your thoughts are too about this part of the many aspects of the strange moment that we're in, is one of which is that we're finding things that people in the psychedelic space really hoped for, was like more acceptance by government agencies and a greater adoption, is coming part and parcel with things that typically people that are psychedelic inclined are not necessarily wanting, like authoritarianism and greater
mhm.
militarism and such. So we're getting into a strange bedfellow situation here, where like, yeah, we've got a guy at HHS who's willing to maybe sign off on some of these things, but he's part and parcel with a group of people that are increasing the carceral state, deporting people and ignoring due process and such. So
And
how
unethical research, right? Like research that doesn't even recognize the cohorts that are within the research, right? Like we're not even so
say
much
more
research.
about that?
So much of the psychedelic research doesn't talk about gender, doesn't talk about
Mhm.
sexuality, doesn't talk about race. Like how many studies have I read like that where they do not even quantify for those things? And that's a place I would like nurses to be intervening in. Like why aren't we quantifying people's experience of the world? It matters when we're looking at the results. And so now we're going to have because of the restrictions on what can be funded, we're just going to have less and less information. It's not like those people
Yeah.
aren't going to be in the research studies. I assume that they still will be. it's just that there will be no definitive evaluation and understanding of who's actually in those studies, more than we already have, because, most of the research is not done by people who are thinking about who's actually represented in the research, which is why we have so little data on trans people or LGBTQ people. We don't understand the racialized differences. We don't understand how, like if we're talking about it from an international perspective, we don't understand how weird people, you do know this terminology, how the West became weird. This guy wrote this book about Western educated people, and the way that the church, largely the Protestant church, has actually affected psychology and mental health, how we are so psychologically different. And I include myself in that, even though I didn't completely grow up in this country, because I've been very westernized in my thinking of mental health versus people who haven't been affected by those. Like, we don't know how research actually affects people who are not from weird countries. Yeah.
Interesting. I want to encourage folks that are watching live to go ahead and drop any questions they have. And there's a few comments coming through, and want to leave some time for questions. There's just so many good things to talk about here. I want to bring our audience into that as well. So thinking about nursing in particular, because, I think, you're really bringing up an important point, because I think a lot of times, we get asked this question a lot, like, well, what are nurses bringing into the psychedelic space? And what I'm hearing you say, and tell me where I've got this wrong, is that nurses are really, because we are so frontline, we really understand in a way our patients, what their lived experiences and what they're coming to us with, and that it's our job to kind of represent that on the other side of the interface. We're kind of the semi-permeable membrane between like our patients' lives and the inside of the medical establishment. We're like that first
For sure.
first layer. And so, what do you think nurses bring to this, and what do nurses need to be learning in order to really kind of optimize their role in order to bring more sort of justice into this conversation and this work?
Yeah. Well, I mean, first of all, I love the idea of a semi-permeable membrane. That's very cellular of you, which is really a cool. It's a cool way.
Science nerd, yes. Yeah.
I see you. I see you. I think one big thing that we do in healthcare and clinical care in general is we moralize about what is good and healing and bad and outside of a clinical setting, and, many people are doing psychedelic experiences in underground communities. And I think you are somebody who is a really good example of that too, collaborating with not that you're doing psychedelics, but that you're collaborating with people who are, in rave scenes, and people creating underground support networks, which, are already happening. Because often these substances, I mean, let's say you are in a state where MDMA and psilocybin is accessible to you. It's very unaffordable to do it in a clinical setting. And then it becomes about people deserving treatment. And then there's also this language about like what I deserve in order to give someone treatment. Like, I deserve to get paid this much, but it's really code for affordability, right? Like, it's really code for that. And that's just deeply rooted in capital, and which is rooted in this white, cis-het, able-bodied supremacy. So if people want to do psychedelics out of a medical setting, they should, and they should also be able to have deep support from us as nurses. Understanding how their psych meds, like a conversation I have with patients all the time is, look, I like to think about psychedelics in terms of like how they affect my patients. So if you're going to do them, we can first of all do integration and preparation. You can do those things with me. Go have your experience. Preparation, have your experience, and then integration with me. If you want to do that, you don't have to do that, but you can. And we can certainly talk about how your psych meds interact. And also, what are your goals? What are the things you want to come out of this experience? Do you just want to have fun? Great. That's fun. That's good too. Like, we need to have more fun and enjoyable experiences. And I also think that if people want to come to us for care, that we don't make it so that it costs $3,000. Like, I know psych NPs who charge $600 for a 3-hour intake. Like, I don't know, like who affords $600 for a 3-hour intake? You
Mm-hmm.
know, I think we have an idea of what those people, where those people come from. So I think that's part of my question. I think understanding crisis is a really important part of training for people who want to work in psychedelics, because I don't think, honestly, I don't think anybody needs an advanced degree to work in psychedelics. I'm not, I think about all of these degrees as clubs, if I'm perfectly honest. Like, they really are. That's like, what is the difference between a good nurse practitioner, a good physician, and a good physician associate? We're different. We're different people, right? But like, we can all offer good care. And like, sometimes when I meet a physician and I like them, I think that they're a nurse practitioner, because I'm like, oh, you actually have a good personality. But like, it's one of those things where I think that we have really invested in these clubs. And look, you can see all of my letters at the top of this thing. I have obviously invested in the clubs, because they are a means to an end. But I really think that we need to train other people too, and also how to understand crisis, how to do, basic life support, do trainings around that, how not to panic in a crisis. A lot of nurses don't know how to not panic in a crisis, especially if they've only worked in outpatient care settings. They don't know what it's like for someone to be in cardiac arrest in front of you,
Mm-hmm.
or overdosing in front of you. So it's really like, how do you train yourself to not panic in those situations? Because panic almost always leads to problems for the person who is experiencing the crisis.
Hmm. Yeah, let's there's a lot to be said in there. I mean, so out of I think some of that panic comes out of, a real genuine sense of responsibility, right? People see something going wrong and they, oh my God, I have to fix this, right? I have to resolve this situation. And I mean, I suppose when you're, you know, running a code, you do, right?
Yeah,
But there's different ways to run a code, right? Do you run it with
absolutely.
your hair on fire, yelling at everyone,
Yelling at
you know?
everyone, and like no
Right.
one knows how to like be calm around you, or are you firm but
Yeah.
moving through the process so that the
Yeah.
person can get the care that they need?
I have to say, total aside, but I've been watching that TV show, The Pit.
Oh, I haven't seen
Speaking of,
it.
it's really worth watching, if
Okay.
nothing else, I mean, because that's what I want to do after a long day at work and healthcare is watch TV about healthcare. But, nevertheless, it's really interesting because they've clearly chosen to demonstrate a very different way of teaching that is
Mhm,
not abusive and that is not panicked and that is
mhm.
it is like deliberate and measured, and it's really cool to watch because you
That's
realize like media reflects and also creates culture, you know so
absolutely, because I remember I watched an episode of Grey's Anatomy, and there was a surgeon hanging an IV, and I was like, "I'm not watching this anymore." Like,
yeah, all right,
just
yeah,
realistic.
yeah,
You know?
yeah, like
Yeah,
when the three doctors in House do everything except run the cafeteria.
exactly.
They're like, now they're drawing blood. Now they're running an MRI machine, right? Because
Right.
that's what doctors do is they run MRI machines. No.
Yeah.
Um, yeah, but this idea of like, how do you get comfortable with crisis so as
Mhm,
to not make not only not make it worse, but to be trauma informed, of course.
mhm.
Um, but also, that how you respond to somebody is going to have a much longer impact than you think.
And also, I think it speaks to, stay with me for a second,
Sure.
the like, for those of us who have experienced a lot of trauma in our lives, we are more comfortable with trauma. We can also be activated by it, but if we are willing to work through our activation around trauma, we are more likely to be calm than somebody who's had a very like happy, healthy childhood and upbringing. You know, like
Right.
it becomes a place where you can think because you've had to think
Yeah.
when you've been in that situation. You've had no choice but to survive. So now you can give that to someone else. And that's why I really I believe in the power of transforming through trauma too, so that you can be present and willing to give of yourself in a way that you had to figure out to give to yourself in
Mm.
more situations in your life.
So it really becomes it becomes a core strength
Yeah.
and not a liability. There is a question here. I don't know,
Oh,
Ronica, what you did for your doctoral, for your DNP work, but there's a question here because we get this question asked a lot about like, I'm working on a DNP capstone. I want this to be something about psychedelics.
mhm.
Or I'm working on a dissertation. I want this to be something about psychedelics. Like, where do you see there being real gaps in the sort of nursing literature and the way that nursing thinks about psychedelics, and where could we fill that in?
I love this question so
It's a
much.
great question, isn't it?
Yeah.
I know. Thanks, Kelsey.
Yeah, thanks, Kelsey. Well, so first I'll say that when I did my doctoral project, I did it on trans care. So
Hmm.
relevant, but not specific to psychedelics.
Hmm.
So here's so I'm starting this project in the fall that I think we need more of, which is working with people in prison reentry programs. So
Hmm.
people who have come out of prison and are in some sort of community support program and doing groups that include ketamine assisted psychotherapy in them as part of the transformational project, and to work on post incarceration syndrome symptoms
Hmm.
and PTSD, right? Like the PICS has never been recognized by the DSM, like many types of PTSD, but the post incarceration syndrome symptoms are different than like, well, I won't say they're different, but they are more specific than just like the kind of generalized category of PTSD. So I
Hmm.
would love to see work like that, or detention, or some sort of carceral system, like
Yeah.
the aftermath of carceral systems and how to address them in doing community-based work that isn't just like you do ketamine by, but like
Hmm.
building community with people and helping people get resources and those kinds of things alongside ketamine.
I know we're getting close to time here, but I can't pass up this opportunity to ask you. When I think of like psychedelics and carceral systems, I think about Timothy Leary's Concord Jail experiment.
Mhm.
Where he was looking at like, are people less recidivistic if they've had psilocybin? And I think like a lot of Leary's work, it was kind of suspect and probably had his thumb on the scale. But um,
Yeah.
what are your thoughts about that?
I don't remember what the data is that came out of
Yeah,
it. I'm
I
sure.
don't remember. I think it was kind of fuzzy, like a lot of the data from studies
Yeah,
back then.
that's
Yeah,
what I remember about that data.
yeah.
But so do I think psychedelics are the answer to people ending up back in jail? No. Do I think a lot of like giving people access to all of the things they have been denied access to, um, not making prison records a reason that people can't get a job? Like, why do people have to
Mhm.
look at people's prison records, right? Like, you can't. I mean, look, maybe you could say there's an argument for someone has a history of sexual abuse, they can't work with children. Like, maybe you could say that. I don't know the sense that we actually know how many people sexually abuse people because they generally don't
Mhm.
go to jail, right?
Right.
But the truth is that like that that part of coming out of prison is one of the worst parts, is that it's impossible to care for yourself. It's impossible to like care for your family, or
Mhm.
b- pay for an apartment, like all of the basic things that you want to do, and also not have everyone in your workplace know about it. So
Right.
I think that that's part of the picture. I also think having community reintegration that includes the community, having restorative justice be a part of that reintegration. One of the people in my book Ronald Leftwich is a prisoner who's going to be in prison for the rest of his life. And he is in a restorative justice. He runs a restorative justice program in MsA, Manhattan Correctional Institute in Norfolk, that is really about these young men who are leaving prison and going back to their communities and being able to have these restorative justice conversations with people who are the family members or community members who have survived violence that has been committed, or the person themselves. And I think that stuff is very poor. I know that stuff is really poorly funded, and so important for people to actually not only get care that they need, but be seen as important community members in where they're going back to. So ketamine can be part of that process, but it doesn't have to be like, I don't think it's the most fundamental part of it.
Well, it's funny, we throw this word integration around a lot in the psychedelic space, right? You know, oh, you had this weird experience and now you have to figure out how it sort of splices back into your day-to-day life. Well, I mean, prison has got to be a huge weird experience, you know. Weird.
Yes.
I mean, weird barely scratches the surface. Obviously, that's a poor choice of words, but it's a non-ordinary state of being.
And I think coming back after 5 years of prison, even 2 years of prison, is an altered state of consciousness.
That makes a lot of sense.
What does the world look like? Like, what does your phone look like? What's the website to pay your bills? Like, all of that stuff changes so quickly, and it becomes like you're in this future reality because time has frozen in a lot of ways for you while incarcerated.
I met Leonard Picard, you know, who was the prodigious LSD. If you took LSD in the 90s, you probably took Leonard's LSD. It's kind of his tagline. No need to incriminate oneself. But you know, he went to prison, I think, in 1999 and was serving, well, I believe, life. And he's now in his mid 70s, and he was released under his sort of compassionate release during COVID, because he was 70 something. And he said he, you know, got out of some federal prison in, I think, in Arizona, and they dropped him off at the bus station with some money and some clothes. And he was trying to get back to New Mexico, and he asked some guy, "Can I use your phone? I'll pay you $5 if I could use your phone." And the guy said, "You don't need to pay me. Here you go." And he hands him this iPhone, and he looks, and he says, "I don't know how to use this." You know, because iPhones came out in 2007. He went to prison in like 2000. You know, so to your point, it's a very weird world when you get out. Well, we have a traditional way of kind of ending these conversations, which, you know, since I think one of the reasons people come to these is for a little bit of advice and guidance. And so we like to do a little parts work here and ask you, if you could advise your younger self anything here, what would you tell yourself?
I would say love yourself more, judge yourself less. No one's better than you, and you're not better than anyone else. Make mistakes, apologize easily, seek every adventure you want to, and worry less about whether or not you're going to be able to support yourself when you're old. Don't buy the trappings of capital embedded white supremacy. Your community and love for them and yourself are your biggest strengths. Seek the unknown and revel in all the things you do know.
Wow. That's wonderful. Ronica, I knew when we met we would have no problem chatting for an hour here, and I hope the folks that have been watching at home, and I know this will get watched many times on the archive as these videos are. So really want to thank you. Can we see your book cover one more time? You've been very usually when people promote books, they I've noticed they say, "In my book I talk about."
I did it twice.
But we did put the link to the book in the chat, and so please do check that out. And really want to thank you for being here and all the work that you're doing. Really, all the work you're doing for your patients. I mean,
Thanks so much for having me, Andrew. I look forward to seeing you.
Yeah, thanks, Ronica. See you in Denver.
See you in Denver.
Okay, bye.
Bye.